You're listening to the Psychedelic Couch. Before we delve into today's episode, which includes conversation around psychedelics, we want to remind our listeners that the use of illicit drugs carries significant risks and legal consequences. Psychedelic substances, including but not limited to LSD, psilocybin, DMT, and MDMA, are classified as illegal in many countries, including here in the UK. The possession, distribution, and consumption of these substances can result in legal penalties, including fines and imprisonment. Furthermore, the use of psychedelics can have profound effects on one's mental and physical health. While some individuals report positive experiences, such as expanded consciousness and therapeutic benefits, others may experience negative effects, such as anxiety, paranoia, and psychosis. These substances can also interact unpredictably with medications and exacerbate underlying mental health conditions. They are also not suitable for anyone under the age of 25. It's essential to approach the topic of psychedelics with caution and responsibility. The views and experiences shared in this podcast are for informational purposes only and should not be interpreted as encouragement or advocacy for the use of illegal substances. If you or someone you know is struggling with substance abuse, we encourage you to seek support from qualified healthcare professionals or local addiction support services. With that said, let's proceed with today's episode, keeping in mind the importance of informed discussion and harm reduction. Frederico Magalhães is a psychiatrist and psychedelic guide whose work has focused on the potential clinical application of psychedelic medicine. His main areas of interest are the therapeutic frameworks and process of psychedelic therapy for people with mental health difficulties, the inherent challenges in this work, and the experiences of both participants and guides. Frederico completed medical training at the University of Porto with a master's thesis on mindfulness-based therapies. He specialised in psychiatry in Oxford, where he's currently an NHS consultant psychiatrist and collaborates with the Oxford Ketamine Clinic on psychotherapeutic interventions. Frederico is an honorary clinical research fellow with Imperial Centre for Psychedelic Research as a study psychiatrist and psychedelic guide on depression and anorexia trials. He is also a member of the Royal College of Psychiatry Psychedelics Working Group. Good morning and welcome, Frederico. So, as a psychiatrist and a clinical guide at the Imperial College Centre for Psychedelics, I know you have a specialist interest in how psychedelic therapy can be used for people with mental health conditions. I thought it was important just to set the scene, and I wanted to talk about some government data that was published on the 1st of March, kind of really highlighting the problem that we're facing. So it's estimated that 1 in 6 adults have experienced a mental health disorder like anxiety and depression in the past week. Waiting times for NHS talk therapies vary from 4 days to 79 days, and the improvements that people experience really vary depending on social groups and where in the country they find themselves. The NHS in England spent 16 billion on mental health services in 22-23, which was 14% of the NHS funding for the local authority. And around 20% of children aged 7 to 16 had a probable mental health condition in 2023, and that's up 12% in 2017. So there is no doubt that we are facing a huge issue. How are you experiencing that in the work that you do in the NHS in CAMHS?
Yeah, how are we experiencing it? I think I just add to that at the tertiary level, secondary level, which I work, we're seeing a doubling in referrals actually, probably in the last 5 or 6 years. So that's some more specific data, kind of what we're seeing with similar kind of cost structures or resources. So you can imagine that this places a great demand on teams, and I think some overwhelm as well, and also maybe it's possible that we're not able to deliver as close or as good quality care, as we'd like to, because we're necessarily kind of diluting ourselves a bit because we just have a lot more young people to look after. I suppose we need to keep focused on our kind of mission, which is of providing the care, and being as available as we can be, but and to not get, I suppose, not get too drawn into these spirals of things being too difficult, or but at the same time, yeah, I think there's a lot of room for improvement, especially in terms of funding and resources. Yeah.
And what do you think, and we know there's been a big increase since COVID, what do you think is driving those figures?
The increase in COVID, I think there are so many reasons for that. So, for example, thinking about eating disorders, that's one of the areas I think that's increased the most since COVID. And I don't have any kind of evidence, but I think that I've in lots of conversations about this, a lot of different ideas. So, for example, perhaps young people who are really motivated, who have a kind of a perfectionist or motivated mindset, where schoolwork really relaxed and they didn't have as much to focus on, as many activities or as many gauges of success, maybe began to turn more to their self-image as a measure of success. So that was one of the things. There was a big push around exercise and being healthy, and then actually just having to spend a lot of time looking at yourself on camera. I
Mm.
think that might have been an important thing, or you can compare yourself directly with who's around you, and then finally maybe a magnification of dynamics within, stressful dynamics within families that young people just couldn't get away from. And we know how sometimes eating disorders speak to are kind of might be kind of a revolt against certain situations, or yeah, or a manifestation of stress in families. So I think so. Just thinking about eating disorders, but a lot of those ideas will then just, I think, are also applicable to all the other things we're seeing. And then I'd just add as well, there's something about not being in school that for some young people was really difficult and left them, in a bad shape, so to speak. But for other young people, it was lovely not being in school. Like it was perfect for them. And then going back has been super, or they've never been able to go back. And they've just got habituated to being very safe in their room. So especially people who experience kind of social overwhelm have found the transition back into school very difficult.
Oh, yeah, and can you tell the listeners about the link with eating disorders and autism, just while you were talking?
I think that I think increasingly we're seeing that there's significant overlap. I'm not kind of super abreast of the latest research into that, but I think what I would say is that if someone who has autistic traits or an autistic spectrum disorder, things can get quite a bit more entrenched. That there's sometimes difficulty in seeing things in a different way. Things are often very kind of black and white. People can get, I think, more stuck in the context of autism. And then it also speaks to things like that are important in autism, like routine or ritual or actually very fixed interests. So you can see how those are all applicable in anorexia. If someone gets really into losing weight and being a certain height and shape, how the autistic mind sort of does have some overlap with that, or certainly things that potentiate that sort of mission to be low weight.
So before maybe we go into the work that you've done in the field of anorexia, perhaps we could take a step back and look at the overview of the use of psychedelics and their potential help with mental health conditions. How do you see the role of psychedelics helping us in this crisis that we face?
So the role of psychedelics and the crisis that we face. So I think I think looking at things from a broader perspective, so not maybe COVID accelerated things or the last 5 years accelerated things, but maybe looking at a broader context of what's going on in society in general and how we're becoming kind of more disaggregated, how we're losing kind of shared meaning, shared ritual, community support, and yeah, I think all of that is possibly contributing to the mental health crisis that we're seeing. And I suppose psychedelics do, by their nature, I think, bring in a kind of a different approach to mental health problems, or a different language, or because they're not so much about symptom resolution, I think, as they are about developing insight, or actually the combination of those two. And then often through that insight come ideas that I speak directly to these issues, these broader issues in society. And so people do, following a psychedelic experience or therapy, have a great openness to connecting with others, or to the importance of other people, to investing in relationships, or or yeah, investing in who's around them, and so I suppose in a way that psychedelics speak to some of the problems at the origin of this mental health kind of crisis that we're living through. So I think that's interesting.
Mm.
I think that in terms of actually addressing the individual patient's difficulties, I don't see that they're going to make a significant difference for now because, I mean, pragmatically speaking, it's not going to be accessible. And so I can think a lot of when we can talk about that, a lot of different ways it's like so interesting on an individual level and kind of more interesting than some other treatments on an individual level. But at a community level, I can't see that it's going to really make much of a dent in the crisis because it's going to be so expensive and so difficult to deliver at scale whilst maintaining the kind of care that you need.
You tell us more about the benefits in individual cases.
Yeah, so in terms of individual, so yeah, I suppose how it changes things at an individual level is that perhaps we can move away from this kind of symptom resolution focus, where we're just kind of trying to help people not feel as bad about, or be as stuck, but through a kind of just taking medication, feeling a bit better. But so and it moves us more towards a kind of I suppose a sense of growth or change with a bit more agency to it, with a bit more understanding to it. And to me, that seems a bit more sustainable. And actually, yeah, to have a lot of other spillover effects that seem that might be really, really helpful.
So at a deeper level, kind of bringing us into connection with ourselves, so that we can move into connection with each other, which works on, I guess, processing some of that chronic stress.
Yeah, 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 people I think often have a sense of being stuck in their lives, stuck in loops, stuck in patterns of seeing the world, and stuck in stress, and then having this moment or this time where you have a bit of relief from that, or can see things in a different way, or have maybe insights into what you could be doing differently, and what might be holding you back. I think that although that all adds things that, generally speaking, just medication on its own might not. Um, from the other point, I mean, we do have psychotherapies already, which kind of already do all those things, but perhaps they do take a bit longer and maybe don't go as direct to the person's individual needs or story as the same way that psychedelics do.
Mm. Can you explain a little bit about how the mechanism of action is different with psychedelics from other traditional medications?
I think in terms of the pharmacology, if we start there, I mean, the most widely used medications used in psychiatry are um, SSRIs, and they have such a variety of potential applications, and their SSRIs are serotonin reuptake inhibitors. That means they reduce the amount of serotonin that's taken. Initially, they reduce the amount of serotonin that's taken up from between your neurons. And psychedelics work also on the serotonin system and on some other systems, but in a different way. They direct ligands, or they attach directly to the certain serotonin receptors and other receptors. So that's mechanistically that's the main difference. And also, I think there's some evidence that psychedelics are more potent potentiators of neuroplasticity, also through different pathways. So I suppose, yeah, speaking to the kind of pharmacology of it, those are some of the main differences.
And what is the impact? That different the way that it acts on serotonin in a slightly different way. What impact do people experience in terms of kind of blunting of emotions?
Yeah, so some people, yeah, there's a few things to say there. I think some people do report um, blunting of emotions with SSRIs as one of the effects of it, and sometimes a helpful effect because they're finding themselves completely overwhelmed by emotion. For other people, it's an uncomfortable feeling, um, but there's also a bit of overlap with, for example, depression itself, where there often is a blunting of emotions to begin with. I think what some of the evidence is showing is that psychedelics, qualitative and also some other evidence is showing that psychedelics are almost kind of opposite to that, in that people start to feel their emotions more deeply in the acute stage and also afterwards, and report being kind of more connected to their emotions. So there's a difference as well between the two approaches as well, I think. Yeah.
And as a sex and relationship therapist, I'm interested on the impact that it has on sexual function. I know that SSRIs can negatively impact sexual function for patients. Do you know much about the research taking place in that area?
So I think there was a paper that came out of our center very recently, around comparing, looking at the psilocybin for depression trial that was a randomized control trial comparing it to escitalopram, and there were findings in terms of of different the relational outcomes and sexual satisfaction and so on. I don't have the data in mind now, but yeah, just it's out there if you wanted to have a look at it. Yeah.
Yeah, it's looking promising that there are kind of positive impacts on variety of sexual function, um, for people using psilocybin as opposed to SSRIs.
Right. Yeah, that might be one of the benefits. That yeah.
Mm. How do you see psychedelic assisted therapy fitting into the broader landscape of mental health care?
Like I said, I think pragmatically, it's not going to be that accessible. It's even if you take a very basic unit of treatment, 2 guides, preparation, dosing, integration, probably looking there at about 30 hours of clinician time, which is probably, yeah, it's far and above what most people would have access to
Mm.
the NHS. So it's an expensive treatment, and I think because of that, it will be it will be limited initially to treatment resistant or difficult to treat conditions, like enduring anorexia, like so-called treatment resistant depression, like say OCD that hasn't resolved with other treatments. So I think initially that's where I see it coming into the mental health, um, yeah, to the mental health offer at a national level.
Yeah, at a national level, and I suppose then the worry is that it increases the gaps between the private sector and public, that people would be seeking these treatments by private means.
Yeah, I think that's probably going to be a case. I'm not sure. Yeah, not sure what kind of percentage of the population. We've already seen some prices coming out for like ketamine assisted therapy, and it's already quite striking, the kind of prices. And ketamine is generally delivered over 40 minutes or an hour. So when you think about the implications of psilocybin, where you can have 8 or 10 hours in a room with two guides, then you can see how, yeah, that's going to drive the price up even more. So I think, yeah, it's going to be in the private sector. It's going to be a treatment for people who can really afford it. There are other worrying kind of trends. I've seen one clinic that offered kind of loans with so that people could do the treatment, and then they have the risk of people kind of getting into debt to
Mm.
access this kind of treatment that they have really high hopes for, and really kind of yeah, inflated expectations of, and then stuck with the debt. Um, so yeah, I think even in the private sector, I don't think there's going to be that many people accessing it, to be honest, unless we start to think about things like group treatments, and or people start really cutting down on the care that's offered, and that
Mm.
will also make it more accessible. But that's got its own dangers, hasn't it?
Mm, absolutely. Could you tell us a little bit more about the legal and regulatory challenges that are surrounding the use of psychedelics in psychiatric treatment currently?
Yeah, so at the moment, with the exception again of ketamine, it's very difficult to do any kind of treatment. Well, it's not possible at the moment to do any kind of treatment outside of clinical settings with these substances, and even in the research settings, it's really much more expensive than it needed to be, because of the way that these substances are kind of scheduled. So yeah, it's quite striking, that they'll be delivered to the research centers in kind of armored vehicles, whereas often, yeah, whereas actually you can get the active substance is very readily available in fields and forests, and another part in parts of cities, and so that's quite a striking kind of contrast, isn't it? That something that's so readily available could also be so expensive in a where it's most needed. So yeah, so that's I think that's the main difficulty at the moment. There's loads of barriers to starting this kind of research. Yeah.
And can you tell us a little bit about some of the potential risks and side effects associated with psychedelic therapy?
Sure. Yeah. In the acute stage, in the right setting, I think what we've seen is it's quite safe, and a lot of the things that will be mentioned as I think already most people already know this, but a lot of things that you might be considered side effects in a more traditional sense or in a more rigorous scientific sense, paranoia, anxiety, sadness, confusion, um, from a point of view of psychedelic therapy, are all more or less expected and experiences to be worked through, and eventually quite can be quite rich or important experiences. So that's an interesting thing. I think that what's considered side effects is often like considered an important part of it, of things. And that's in the acute stage. I don't think there's ever been any kind of major complications in the many thousands of kind of research participants across different centers, at least that I'm aware of. I think if there are, there are probably very few. Um, I think the risks are much greater in the longer term because um, psychedelics can really quite disorganize people, especially if people have psychopathology, quite a well established psychopathology or something that's started quite early in their lives, and um, then I think that's even an even higher risk. That people have got these kind of strong defensive structures around early difficulties, and that somehow psychedelics might disorganize people and bring those difficulties up. But then, yeah, so it can leave people feeling really quite perplexed afterwards, or not clear what to do next, or having received a message, perhaps, or an insight that doesn't completely align with what they were expecting, or uh, it can create tension in relationships or crisis in relationships, which I think you'll be quite well aware of. And sometimes often crisis leads to growth, doesn't it? So it's not necessarily bad. On the more risky side, there's a risk of psychosis that we know with psychedelics. Fortunately, as well in research trial, possibly due to quite strict screening. I don't think anyone has ever really reported that effect. Yeah, some people can get quite stuck afterwards with different kind of problems. And I remember one person, not in a clinical trial, it's more anecdotal, but I think it gives a nice picture of the type of problems. Someone who had a beautiful experience of kind of nature connectedness that was kind of life changing. I mean, and they moved into a career that was more nature oriented or ecology oriented, but at the same time they became quite obsessed with litter, and walking down the street couldn't not stop to pick up litter, regardless of where they were or how busy they were. So I think that's like a little anecdote, I think, of how there are risks, especially if the aftercare isn't there.
Exactly. Well, I suppose it emphasizes that need for the integration and that support, that ongoing support to be there, maybe in individual work, but also in that group kind of community setting.
Yes, yeah. So yeah, that's an interesting question for healthcare systems and for private providers as well. What is that support going to look like? Um, and I think peer solutions are going to be really valuable.
Mm.
So I think that the main thing, I was talking to someone about this yesterday. The issue with psychedelics treatments, I think, isn't so much, for a lot of people, it will go well and they'll be fine, and they'll they'll gather those insights and that experience and move on into their lives with them and make some positive changes. The problem, maybe it's a bit obvious what I'm saying, but is that for some people, it can be really disorganizing or disorienting. So how do we make sure that the support is in place for those, specifically for those people? That's where the greatest need lies.
And I suppose ultimately we don't know until they're down that path. You can't know what your response is going to be. So ensuring that that framework is there or that support is available
Yeah.
in case it does really, shake up the system.
There's got to be those safeguards in place and quick identification, I suppose, of when things aren't heading in the right direction, and quick mobilization of support on the background of a more generic kind of community focused support. It's going to be a challenge. Yeah.
Mm. And I was thinking, how do you navigate the public perception and stigma around psychedelics? But then I was wondering if perhaps the pendulum has swung the other way, and it's less about that they're now seen more as a kind of panacea, a blanket solution for many things. How are you experiencing the public's perception of psychedelics now?
I think the ship has sailed to some extent in terms of stigma and yeah, I think it's very much in the hype phase where there's just much more general excitement than any kind of than stigma, or and that's yeah, and that raises its own difficulties, doesn't it? I mean, if there is too much excitement or positivity around something, then it can lead to a more kind of unbridled use of it, and actually some of the more difficult aspects of it can be left out. I think it's interesting. There's a lot of like there's a lot of ego involved in these swings as well, isn't there? So people riding the coattails of the hype, so to speak, and really, being kind of evangelists for and sometimes people who speak the loudest aren't the most wise, the loudest voices aren't the wisest voices. And then on the other side, you've got maybe like a counter movement of around all the dangers and stuff, which is super important as well. But I'm also aware of the role of ego in that as well. So if you weren't the first to kind of to sell it, you can be the first to knock it, and the loudest knock it. And so I'm a bit wary of both extremes.
Yeah, to tell us more about your personal work. You as a psychiatrist and collaborator at the Imperial College Centre for Psychedelics. What has the focus of your work been?
I've been involved in trials mostly as a psychiatrist and guide. I worked a bit at the tail end of the randomized control trial for depression, and then more fully on the psilocybin therapy for anorexia trial. And then since that the clinical side of that kind of wrapped up in June of last year, my involvement has been kind of more tangential. I've been very wrapped up and absorbed with my day-to-day work in CAMS, and I've had less time than I would have liked to kind of stay involved with that team. But yeah, essentially, it's a psychiatrist involved in screening, involved in kind of developing the initial protocol or adjusting the initial protocol, and getting the trial running from a clinical point of view, and then the kind of work with the patients themselves. The screening was a big part of the work as well, and then the work with the patients and the follow up. Yeah, so those I suppose that's been my main involvement at Imperial, has been around in and around that trial.
And what would you say some of the most interesting or important findings have been from those trials?
So look for me, like looking at the depression trial, I think it showed equivalence to an SSRI, which is the main line, the mainstay of treatment. So that's there's an equivalence there. I think maybe there was a sense, and I think there's going to be more coming out about this, but that the main measure that was used didn't fully capture the difference between the two treatments. They were actually they didn't separate on the main measure, but then looking at secondary measures, psilocybin seemed to perform better than the SSRI on every measure. But there's some statistical kind of complexity there, where because you're measuring for a lot of things, and and because of chance, you can't say outright that psilocybin was better than SSRI on those 20 measures, even though they all went in the same direction. Can't for any individual one of them, because of statistical issues, say, look, it was better at this, it was better at this, it was better at this, better at this. Yeah. So I think the main finding for that trial, from a very rigorous scientific point of view, is that psilocybin therapy is at least no worse than an SSRI on the main outcome. But then obviously there's all this other interesting kind of secondary data coming out that will need kind of more analyzing.
Could you tell us a bit more about that, about the secondary
So,
data?
so for example, there was an interesting paper looking at the importance of the therapeutic relationship and how that predicts, how that can predict outcomes. So I think that was quite exciting, and speak to the idea that I think some of us have, that is an essential part of the process and can't be kind of, and can't and shouldn't be ignored or not considered enough. So that's one thing. And then I think more evidence around looking at the more specific psychological mechanisms, and specific kind of experiences. So the way that, say, ego dissolution, the experience of ego dissolution, of losing a sense of oneself in the acute experience, might predict better outcomes, or how the experience of emotional breakthrough, again, according to certain kind of measures that we use, can predict positive outcomes. So that's the kind of things that are being unpicked now out of that.
So that the experience in the psilocybin session itself then being connected to future outcomes.
Yeah.
And tell us more about the panorexia pilot study.
It was a trial with around 20 participants, with 3 treatment sessions, without speaking about the doses, and using quite a classic kind of model of preparation, dosing, and integration for each session. The criteria was kind of people who have had anorexia for more than 3 or 4 years, I think, for whom other treatments hadn't worked. It was important that people were open to an NHS team. That was an important part of it, that they had some support structure around them. So those were kind of the main inclusion criteria. And obviously we're screening for things like medical instability and psychosis, history of personal family history of psychosis, things like that. So that was the kind of the patient. It was with female participants, and that was the kind of the patient group. And then I've spoken a bit about the treatment model. So that was our pilot trial. So again, it's not compared to any other treatment. But I think what's interesting about it is because we're looking at a patient group for whom other things hadn't worked, and because in anorexia, often, if you don't get better in the initial kind of 3 to 5 years, your chances of improving are much lower. I think that if we do see positive results, it would be quite impressive, even if it was only in just a few of the patients. I think that we'd find that quite impressive, because it's such a difficult to treat condition.
And what about it being used more widely? I was thinking not just kind of eating disorders, but general disordered eating.
I think as agents of change, I think they work quite well for many different conditions. They're kind of transdiagnostic. So I think if people, we have seen that they're important, important mediators of behavioral change, of health behaviors, of changes in health behaviors. And so I think, they would have potential in those more kind of for more kind of non-diagnosable conditions that don't meet strict criteria. Eventually, psychedelics may help people make changes in different areas of their life, including, and it does speak to thinking specifically about disordered eating, and I don't know what specific conditions might be around that, but if it will speak to things like self-image, which is often an important thing, or about the function of that disorder. You might have insights into why am I doing this, or into into certain values. What are my values, and how does this kind of behavior fit with those values, or even like more broadly connection to greater principles, more transpersonal, spiritual, mystical. So all those things can help guide change, I think, or see change. I can see it working.
Are there specific kind of patient populations that might benefit from psilocybin therapy more in anorexia?
I don't think we have any evidence for that at the moment. No, I think the life conditions, the general milieu in which people go back into after they finished the treatment, that's probably going to be as important as individual kind of characteristics. Going back into a family system that can adapt to the change. Going back into perhaps a lifestyle, or going back into jobs, or going back into relationships that can adjust and adapt and kind of um, promote that possibility of change is going to be as important as individual characteristics.
I suppose that invites the need for systemic change rather than just changing, kind of work on the individual. How do they then integrate back into their wider family, society, community?
Yeah, and absolutely. And I think that kind of really speaks to your expertise, isn't it? How does a system change? How does a system react when one person wants to change and the others might be kind of scared of change, or scared, yeah, or what that change might mean? Do you have any thoughts about that? Okay.
Well, I suppose it comes back to that kind of community piece, doesn't it? When we do the work in isolation, you kind of come back into your world and feel very discombobulated, very alone. So there's something about the need for, you know, systemic change. Um, I often think about this in terms of my work with couples. How important it is that the relational work is done with parents, so that it can hold the system, and how important that is in society. Um, just thinking about some of the retreats that I go to, and it's going off on a tangent slightly, but it's often predominantly women. At the end of I don't know, a Kundalini retreat, maybe, there's this sort of slight fear actually of what it's going to be like going home. How do I integrate what I've learned here? How do I bring this kind of community spirit back home with me? And part of my work is wanting to do way more of that work with couples. If you can do it so that that structure is kind of really strong and healthy, it's easier to then move back into the home system, so that you can have these sort of family manifestos.
Mm, mm,
For
mm.
me, that there's so much I reflect. It is what we're experiencing in the wider world, a result of chronic stress, of chronic loneliness, of individuation. We're so kind of governed by our goals and structures that start when we're at school, right? It's all about that very male masculine energy of achieving, power forward, and we've lost that softness, that quietness, that stillness.
Mm.
So it's really kind of complicated how you balance, how you bring that in, to a system like the NHS.
Yeah, yeah, that's a really good point. I wonder maybe if I was also talking to someone about this yesterday, how it may be that it may be helpful to bring in a family, as part of preparation for a psychedelic, so that the preparation isn't just with the person, but rather there's a kind of formulation within the family
Mm.
or within the partners or within the couple of what change might look like. Or
Yeah, and I suppose if we think about how these medicines have been used for hundreds, thousands of years within indigenous communities, it's not in isolation, right? It is within the community, within the family structure.
yeah, I think it's quite striking sometimes how I think those in indigenous settings they might not even have a word for or a particular approach to integration, because integration is going back home, isn't it?
Mm.
It's always there. There's always an understanding.
Yeah, it's a way of living, right?
Yeah, yeah. I sometimes worry a bit about that because because it might, because if you have that approach, then you might not have so much insight into, if people are visiting your community to do some work with psychedelics, then they go back to, but then you might not have as much thought to what it would be like to go back to wherever you came from,
Mm.
as a guide in those settings. You might be really attentive during the sessions, and you might be really caring, or have a really strong kind of spiritual structure or traditional structure around it. But actually, maybe not as much thought to things like aftercare, isn't it?
Mm.
Yeah.
Mm.
We see people coming back from Peru completely discombobulated. That was a good word you used.
Yeah, and that's what I was just thinking about. People, kind of tourists, ayahuasca tourists that go and spend a week, a month, 3 months in the Amazon, and then how you integrate that back into the frenetic world that we live in the West.
Like, yeah, I mean the communities are growing, aren't they? These integration groups, and more clinicians are putting, integrate psychedelic integration in their kind of taglines, and I think there's more. more and more on offer in terms of support.
And I was thinking the group, the work that Ros Watts has done in terms of the group integration programs. So that's a kind of an annual program that you're part of, and how the huge benefits of that.
It's really lovely model, yeah. And then with the nature side of it as well, bringing the yeah, and the sense of seasons and things like that. Yeah,
Mm.
it's really. I mean, yeah, if that models like that can be scaled, it seems it would be very positive. Yeah.
Are there any patient populations that you think would really benefit from psychedelic assisted therapy, but also some that really should be avoided?
So I mentioned the word transdiagnostic, and we do have a sense that for most conditions where there is perhaps the theme really is of stuckness or entrenchment, or I've seen a word recently, canalization. So there's a kind of a feeling of an important cognitive element. So people are really stuck in a kind of a worldview or and a behavioral element, like certain behaviors. Then that speaks to a lot of different conditions, doesn't it? Depression, all the anxiety disorders, all the spectrum from OCDs, social phobias, agoraphobia, yeah, all the different aspects of that. Anorexia is an obvious one. Addictions, especially as well. So I think it has potential in all those fields. The ones that we're being more cautious about now are anything that might touch on kind of mania or psychosis, because those are obviously quite severe outcomes. And so, but I do know that there's some evidence now of treating depression in the context of bipolar disorder. So people are getting a bit braver about the indications for it. I wonder, I do have a lot of time for psychological models of psychosis, and for psychosis as a defense against against well, as a defense, yeah, as a kind of a protection against things that are impossible to cohere or to make sense of, or an impossible stressful context. So I think that I'm not completely opposed in the future to thinking about doing it in doing a safe as way as possible, but of these kinds of substances for treating psychosis, or psychotic disorders. But again, especially kind of more chronic, lower grade conditions. So yeah, I wouldn't be complete. Yeah, I think we at the moment we're being really careful, and I think that's why we haven't seen any of those kinds of outcomes. There's another kind of frontier, which is the so-called personality disorders, and again, I think I think we really need to be careful. But there's obvious promise there as well, isn't there? We've seen that it can kind of support personality change, lifestyle change, reappraisal of relationships, so which are all really important in personalities. Also, I think psychedelics could play a role there. Yeah, I think the essential problem there is again of perhaps bringing up very early complexes, traumas, what different words for these kind of things that are kind of been protected from, and then that coming out and that being really disorganizing and distressing in all kinds of ways. And then also I'm wary of the attachment, because I believe that psychedelics can be magnifiers of attachments, and of early and sometimes early life attachments. And so, yeah, if you're developing in this work, you're developing those attachments very quickly. Perhaps to use a psychodynamic was a dynamic word, you're kind of projecting things into the therapist. So there's all this things like transference or countertransference dynamics, quite powerful. And so then you have to separate very quickly at the end, and that could feel absolutely like an abandonment, and really speak to very early, very traumatic abandonment, and yeah, again, very disorganizing in a way. So again, there's potential there, but also significant risk.
And real need for safe container and ongoing work.
Yeah, so that's maybe maybe the container for that would be someone that you've already known for quite a long time, a therapist that you've been working with for a long time, that can then take you in to this kind of treatment and go through it with you, and then sort of stay with you the other side of it. It's almost like, and that's an interesting model, isn't it? Whether in the NHS or otherwise, where you have an established therapist who can then, well, okay, we've done some work, but there's something deeper here. Let's go into the psychedelic therapy framework for, for some sessions, for a dose, and then we can come back out and continue our work.
Mm. Do you see that as a potential model for long-term work?
Yeah, I can see that. I can see that. Yeah, I can completely see that happening. Yeah, I think, and we might see that happening quite soon. For example, in the NHS with ketamine. Ketamine is often used as a medication, like as a very like a in and out, give you an infusion and then carry on. But increasingly being used in a similar way to psychedelics, as a psychedelic as a drug assisted therapy, well, something that's a bit more acute. And I think we might start to see that, where therapists have been working with more complex cases in the NHS for say 20 sessions, 25 sessions, and something feels a little bit stuck. And then there might be a pathway then into the ketamine clinic and then out again, um, with a focus on using that window of change, of opportunity, of that plasticity, window of plasticity, to make, maybe sometimes quite simple kind of behavioral change, uh, and to continue the therapy.
Oh, what about some of the ethical considerations that we really need to be aware of?
Ethical. I think we've kind of touched on quite a lot of them. There's some really nice formulations now coming out of ethical considerations in psychedelics. I think some of the most important ethical considerations might be around who is able to access them, and also around equitable access, but then also we've spoken about the aftercare and the tension with costs and things, and cutting down on certain parameters of it. And so I think that's where the main ethical considerations are. We have to be careful with kind of worldviews and specific kind of therapeutic approaches. So I think not be too suggestible to the people who we're working with, because then in that very um, fragile state sometimes, or very suggestible state, if we're putting in too much of our belief systems, or our models of seeing the world, I don't think that that's necessarily helpful. And then, and speaking more broadly, there's a real risk of exploitation, I think, which we're already seeing. There's a risk of abusive kind of behaviors. So yeah, so I don't have that super crystallized in my mind. I suppose my approach is really I think of careful, of like considerate and care, being considerate and being careful.
Mm. So, how do you envisage the future of psychedelic research, both at Imperial College and in the broader field of psychiatry?
Wow. Well, it's kind of really taking off and exploding in so many different directions. I think that there's a lot of different substances that's going to be a major direction. Okay, it looks like it works for this. Does it work for this? Let's tweak it here. Let's tweak it there. So that's one of the major directions of travel. Component analysis is a big part of it now as well, isn't it? What is actually doing the hard lifting here? Is it the therapeutic relationship? Is it the music? Is it the drug? Is it the therapeutic approach? And that's going to be really, I think, going to have to be broken down. And well, there's a lot of kind of input. There's a kind of lot of impetus in that direction as well. And then we've touched on this kind of new indications, I suppose. And then there's a lot of neuroscience as well. What is actually going on in the brain, and how does it translate into change, or how does it? Yeah, it's in such an interesting field, because I think it really brings together. There's so many different frameworks that you can look at someone's process by. There's the narrative, kind of phenomenological view. You can look at these things through a psychotherapeutic lens. You can look at things through a neuroscience lens, and really, they're all different facets of a same process. Or you don't have to get too stuck, I think, on saying, is it this, or is it this, or is it this? It's all of them, really, isn't it?
Well, it's the combination and the whole experience, right? And then add in that mystical piece that's so hard to measure, right?
Yeah.
What are your hopes and fears for the psychedelic renaissance?
yeah, I suppose the hope is pretty simple. Is that people who need this, who might benefit from these treatments and might not benefit from others, have access to them in the right way with a sufficient amount of care. I try to be a little bit cautiously optimistic about the effects on society, but maybe if these substances do bring about generally helpful insights and do promote things like community and connection, and I think overall they might contribute to positive trends in society, uh, without ascribing to that, put LSD in the drinking water and society will be better. I don't believe that to be the case at all. I think it's a lot more complex than that. But I have some hope that the communities that spring up around this kind of work might influence the broader communities more positively. And so that's some of my hopes. And you mentioned the risks.
Yeah, your fears.
My fears are around individuals and how they might, yeah, not be well looked after, or might be offered the treatments without the appropriate scrutiny of whether it's right for them, and then be left on their own without the right kind of support. I think that's, yeah, that the levels of care, as we get more sophisticated around, okay, what is necessary, what are the main components here? Let's strip away this, let's strip away this, let's strip away this. Maybe you don't need to be in the same room, maybe you don't. And that may be the case for most people, that actually you don't need two guides, you might just need one, or you don't need that much preparation, or you don't need that much integration, or you don't, and they might show that on average you don't. Okay, but then what happens when you do, when there's those outliers, so to speak, that really do need a lot more support. That's my fear, that the levels, as it gets more competitive and more available, that the levels of care won't be there, and that's going to lead to some difficult outcomes.
Is there a question that I've not asked that you wish I had?
No, I think we've covered. Yeah, I I wasn't really expecting any specific questions. Do you have any questions that you wish you'd ask?
No, I feel like I'm sure I will afterwards, but I feel like we've kind of, we've really covered the ground and, done a general exploration. I so appreciate your time, and hugely value all the work that you're doing. So thank you very, very much.
Yeah, so it's a great pleasure. I've really enjoyed talking to you, Claire. I haven't done so many podcasts or talks, so it's really helped me kind of realize maybe also what I need to think about a bit more, what I think I know, and how I communicate it.
Well, you were a fantastic guest. Thank you very, very much.
Yeah, it's a pleasure.
You've been listening to the Psychedelic Couch. For more episodes, please follow me on Spotify, Apple Music, or wherever you get your podcasts, and find me on Instagram at the Psychedelic Couch and at Claire Faulkner Therapy, where I will be keeping you up to date on the latest episodes and information surrounding all things therapy, psychedelics, and expanded states.